Okay, welcome to the Enhancing Clinical Practice and Outcome stream of the SNOMED CT Expo 2023. My name is Michael Jones and I'm a MAP specialist at SNOMED International, and I will be acting as the moderator for today's session. All questions will be answered at the conclusion of the presentation. Online attendees, please use the Q&A button to type your question to the presenter. On-site attendees, please use the microphone provided in the centre of the room. I am now pleased to introduce Leilei Zhu from the University College London Hospitals NHS Foundation Trust, who will be presenting on natural language processing to support preventive care, structured documentation in electronic health records. Our story so far. Leilei, please go ahead.
Thank you. Can you guys hear me okay? You know, when you are short, you get so frustrated with some of these tools. I'm very worried that no one is going to be here, but Michael reminded me that after this session, there's going to be a drink and food reception. So here we go. Thank you so much. Has anyone heard of my trust? Not many people, right? Great. So I work for University College London Hospitals, which is abbreviated as UCLH. We are one of the largest teaching hospitals in central London. We provide both tertiary and secondary care for the local population, or tertiary care for at a national and international level. I think one of the good things about UCLH is we have very close academic relationship with our university, which is UCL, and NIHR, which is National Institute for Health Research, which also means and enabled us to become one of the probably largest hospitals in the country to very much focused on clinical research. So world-class research has always remained as one of our visions and objectives every year when you look at the report. Okay, so our MyAid journey, which is the natural language processing project, and we named it MyAid. Our journey started in May 2020. At that time, NHSX, now it has been renamed as NHS England, allocated £123 million over 4 years to accelerate the most promising AI technologies for health and social care. And the award spans 4 phases with different themes. We applied under phase 2, which is a theme that's develop and evaluate prototype of demonstration unit and generate early clinical safety or efficacy data. So how do we start this? I think in the electronic health record system, oh, right, sorry, I forgot to mention that in 2019, we went live with probably one of the most famous electronic health record system in the world, which is Epic. So we are now 4.5 years into implementation. That's quite a long time. On day 1, we went live. We literally went paperless. So everyone knows that in the electronic health record, right, you have structured data and you have non-structured data, which is pretty much free text. And everyone knows that we have got proven benefits to show that structured data can support clinical decision support, can support patient care. But unstructured data, right now, to leverage its benefits, you either have to go through a manual case review or bespoke data entry, which no one has the time and energy to do. Structured data is good, right? But structured data is not always complete when you have a EHR implementation. I mean, hands up, we had an implementation issue because during COVID, we did a clinical study by looking at our one field in Epic, which is problem list and diagnosis. We found out that 40% of the problem list entries are actually written in free text and not in that little structured field, right, in Epic. So And we strongly believe that this incomplete structured data get clinicians to fill in the boxes in the structured fields in the system is not a unique issue to my trust. It's not a unique issue to the UK. Probably it's a universal issue. So something has to be done about it, because we can't just wait around another 4.5 years and look back and go, what are we going to do about it? So something has to be done. And we thought about using natural language processing. A lot of the natural language processing tools very much focused on retrospective data analysis, change it or convert it into a structured data using data standards. But we found rarely a natural language processing tool that go one step further, which is after we converted those free text entries and we had additional structured data item, what next? Can we inject it back into the source system? Because any data item in the EHR environment, if it's not real time or close to real time, that clinical benefits is suboptimal. So this is the project is about. We wanted to create a system that not only get us structured data, but also feed that structured data back into the source system at the time clinicians are doing their documentation. So the principles and our approach right from the start are very clear. We want to optimize technology, but we also want to focus on human factors, because there is no point implement great technology there, but your clinicians do not want to use it. And we also wanted our software to be open source licensed. And we want to make sure that we use data standards whenever possible to achieve our also concurrent interoperability objective as well. We wanted to have this system to continuously do improvement. We want our LLP system to be able to know what has been accepted by clinicians, what has been rejected, and then feed that results back into the system and then fine tune it. We also want very much patient say into this, because we don't want to introduce a system that gets in the way between clinician and patient interaction. NHS as a whole probably is one of the largest healthcare organization in the world. We wanted to be able to use our example. If we can be successful, we wanted to use it to get other hospitals or other NHS trusts to adopt our approach and then hopefully reproduce that. So this is our proposed ILP system or MyAid. But I think what I'm going to do is I'm going to use how does that look like within Epic. To squeeze 2 years work into a 20 minutes presentation, I have deliberately removed a lot of specific technical details. So just bear with me on it, right? So on the left-hand side, I noticed that pointer only works there, right? So on the left-hand side is the thing that we have already got. We got Epic EHR system. My clinicians interact with Epic system. We also have a thing called Epic Note Reader. Epic Note Reader is a tool in Epic. It's actually just a one click. I'm going to show you a screenshot later on. What Epic Note Reader does is when you click Epic Note Reader, it absorbs all the free text thing, all the free text document from Epic and then send it to a third-party NLP backend using HL7 and the CDA standard. And in the NLP system, it does its magic thing for annotation and and fine tune and then select and then recommend. And it sends back and repackage all these information and sends back to Epic through Note Reader interface again, using the same HL7 and the CDA standard. When it sends back to Epic, it's at this moment, my clinicians do the validation. So the whole process is not automatic. The whole process in the end gone through clinical validation, and my clinician would go, I agree with what you recommended, and or I reject with what you recommended. Let me just do. So our project plan, 5 stages, and even like they go in parallel, very clear defined plan, develop the system, integrate the system within Epic. And also we expected to do a small clinical user acceptance testing. And if it's proven to be successful, we wanted to roll it out as a pilot. And then during that pilot, we want to create clinical evaluation studies and using different measurements to measure, is it successful, measure against different stakeholders like clinicians and patients, is it successful, using quantitative and qualitative approaches to measure that. And then if it's again proven successful, we will go live within entire UCLH, and then hopefully again roll it out in other trusts or show other trusts and how we did it. But I want to mention here, you will notice there is another hospital here called GOSH. It's GOSH. It's Great Ormond Street Hospital, which is a world-renowned children's hospital just down the road from us. So one thing to note that we actually doing this project hand in hand with GOSH. So there are 2 trusts actually involved in this project. Am I talking too fast? Okay, all right. We have always been very clear how we want to use our EHR for. We know and we want to avoid the pitfalls that only using EHR as a record keeping tool. We wanted to leverage the benefits of EHR as much as we can, but we are very clear that to leverage the benefits, it requires high quality validated, and at this moment, structured data. But we are again has proven through our own implementation that structured data implementation has got issues on the shop floor. So we are trying to find a way to enhance that, and we're not replacing the structured data, but we are trying to find a tool to make that gap a bit shorter or a bit smaller. We hope like our approach is fast and minimal obstructive to clinicians, and we want to facilitate real-time clinical validation. And we want to maximize, okay, so I've mentioned that. We also want to optimize this for the entire NHS, using us as a example or a guinea pig. At that moment, in Epic, there is an app which is called My Chart, which is served as a patient portal. So patients can use that app and enter their medication, the medications they take, the allergies that they have. And so every single structured data items using this approach that got picked up, the patients can see it very clearly. And they can view it and they can say yes or no, or I agree or don't agree. So the funding approval. So we won an award, and then the money we won enabled us to recruit 2 software developers, and we named it MyAid, which is Medical Information AI Data Extractor. We established some governance processes and groups. We have weekly meetings in a technical group, steering group meeting probably like every 3 months. And in the steering group meeting, we have patient and public involvement and engagement, because we really recognize that they really need to have their say into this. And we also have an annual advisory group. Most importantly, we defined what clinical data items are going to be in the scope of this project, which is probabilities and diagnosis, medications, and allergies. But I think to complete picture, and I just wanted to add a couple of slides to explain. This is the probabilities and diagnosis looks like in EPIC. You can see that it's already structured, right? So it's the problem list and diagnosis names that's in the scope. But for medications, it's not just the medication name in the scope, it's the dose, the route of administration, and then the frequency as well. And then for allergies, it's not just allergen, it's about severity, reaction type, and then the reactions in the scope. Because we feel like, you know, it should, and these additional data items should form and must form the minimum data set to make that clinical item actually meaningful. So this is the landscape, pretty much like of how the MyIT kind of works. I'm going to, you will notice that I have put 1, 2, 3, because I think that there are 3 basic building blocks to make the whole system work, and I'm just going to explain it one by one, right? The first building block, note reader. I've explained it what note reader is. Note reader allows you to free text in whichever way that you want. You can use voice recognition, you can type, you can do whatever you want, you want, and note reader just suck up all these free text informations. This is, I took this screenshot from EPIC training manual, right? So this is what a note reader looks like. I don't know how to. Oh, sorry. So I highlighted in red on the right-hand side, that's free text, a mock-up free text notes. And you can see I highlighted some of the diagnosis, some of the medications. On the left-hand side, it's the problem list and the medication fields. And then, and here is plus means I accept, remove means I reject. That's how your clinician do the validation. This is that button you press to go to note reader. It's actually quite quick and quite seamless. I'm going to do a demo at the end of this, so you will see. The second building block is the NLP engine. We actually use MedCat, and I'm glad that my colleague Anthony is here, so he will be able to answer you, all the MedCat questions. And we adopt it because note reader itself doesn't do natural language processing. It requires a third-party NLP engine to perform that. And then MedCat is open source. It's developed by NHS, and it's very easy to deploy, and it's a web application. And it's already trained at that time with clinical data. I know it has been trained on Mimic. I can't remember which version, and it's also proven quite good performance. So that's why we kind of took it on. The third one is probably most related to SNOMED CT is the terminology. Maybe it's useful if I just explain or a little bit about the terminology landscape in our EPIC system. We had a very clear vision before we implement EPIC that we wanted to incorporate NHS data standards in EPIC. NHS data standards is pretty much, SNOMED CT, DMD, which is, I know people is going to say it's not SNOMED CT, but the IDs, console IDs is kind of like, it's like SNOMED CT IDs. It's unit of measure, UCOM, and FIRE. However, through implementation, we didn't really, sorry about the spelling, we didn't really manage to implement SNOMED CT in EPIC at its best time, which I always consider the implementation of data standard. The best time is during the system configuration and then build stage. Once that system is built, you're not really doing standard implementation. You are sort of doing a piece of mapping exercise. which I personally don't feel is the most efficient and the recommended way of implementation. That's just my personal view. So this has led to different levels of SNOMED CT implementation maturity in EPIC. I think to have a vision and a grand theory to implement standards in EHS is always good because that's your ultimate goal. But many implementation I was involved, it's always ended up with mixed bag of maturity. Because clinical items are different, how the system build it is different, what your user requirement is different, and then your user digital maturity also are very different. I think that's just life. You know, theory, implementation in reality is you will always end it up with different levels. So through time, we also found that SNOMED CT is not really the best terminology system for lab medicine. And our clinical group decided that we kind of use LOINC now for our laboratory medicine standards, which is obviously not very good because we wanted to speak one language, and also LOINC is currently not a NHS data standard, but you know, clinical always goes first. Right, so related to the 3 data items in EPIC, what is our standards maturity level? Okay, problem list and diagnosis. We initially had a proprietary third-party terminology system that came with EPIC, but we transitioned into native SNOMED CT 2 years post go live, alongside with the patient data. Basically we replaced the historical patient problem from the old terminology system with the SNOMED CT concepts. And we are now using SNOMED CT as both interface and reference terminology for diagnosis problem list. Our medication and allergy, we purchased the terminology system from First Data Bank. Then our route administration, dosage, reactions, they are all custom built list. When I say custom built, which is basically the clinician go, I want ABC, and then my EPIC analyst colleague will go, okay, I will build you, ABC. And when you have things like this, you just have to do a mapping exercise at the back end because it's always too late to change it. So my CT is a referenced terminology. So the progress so far, right. So integrated with EPIC and LP system fine-tuning is already completed. We went through a long process of ethical approval for the pilot implementation. We request a production. So production server is like in a live environment. We also completed a hazard workshop. We are now in the process of preparing a full-blown safety case. We basically aim to commence the study in the late 2023, which is probably next month, and switch to MyAid in a live environment in early 2024. So we are several months late than we expected. And then the good news is we got further funding and award to fine-tuning and improve the system, which is good. The clinical evaluation study we kind of wrote up is pretty much focused on two objectives. The primary objective is to ascertain whether the system works or not, right? Is there any extra correct structured data items being picked up? And then the second objective is to through kind of like a qualitative survey to see how do you feel about it? What is your usability? How is the usability, feel like? Does it, clinician, does it get into your way? Does it really increase your time of documentation, or you find it really helpful? Okay, so this is a quick demo. Let me just see. Right-hand side is we are basically mocking up some of the free text entries. So my clinician click accept to complete the notes, and then the note reader is already seamlessly open. And then now they come to problem list. Here is the clinician go, I agree or not agree. But please also, did you notice that we also have some metadata items that like negated history, because it says patient doesn't have headache. Those are also part of the training that we did. Cool. And you notice that I didn't do the medication and allergy because I'm very, very conscious about the time. So I kind of try to squeeze one to use it as a prototype to demo. This is basically the end of my presentation. I think I'm 5 minutes. And it's a big team effort. And here are some of the acknowledgement. Any questions? Thank you.
Thank you for that, Leilei. It's a very, very interesting presentation. I'm sure there's a lot of engagement. We are running out of time. I can squeeze in one quick question if someone has something they'd like to ask the gentleman here.
Yeah, thank you. I'm Stefan Schulz from Medical University of Graz. Very good presentation. Have you ever considered to go one step further so that NLP analysis is already done on the fly while typing or while recording?
Yes, that's a very good question. I remember the presentation before me, which is that Brazilian doctor Fabio from did his presentation, and then he's a cardiologist, and he mentioned one thing which is really true. And he said, I'm a clinician. When I see the patient, I constantly have to compete for my priority, which is in between documentation without interruption and seeing my patient. What you suggested is was actually evaluated as one of the options, because we had a particular clinical group meeting to discuss when is the best time during documentation to introduce this tool. Majority of my clinicians actually feel that if we do literally simultaneously as they type and then they keep popping up, items, they felt it's a lot more interruption, and they actually preferred to introduce this tool as I demoed when they complete their notes, when they click accept, and then so they can do that check in one go. But that's a very good question. But I just wanted to assure you that we have gone through a lot of clinical consultations before we decided the approach.
Thank you for that. I am terribly sorry, but we are out of time on this session now.
Please, one more question, please.
I'm afraid
I wanted to hear everyone's objections and
there is a networking opportunity at between 5 and 7 this evening. So I'm sure those of you that do have questions for Leilei, they can come in, track you down and have the discussion in the open. But yeah, with that, I'll conclude the session. So thank you once again for a very interesting presentation.